Hello, I'm Professor Alain. I'm head of Medical Intensive Care Unit in Sorbonne University Pitié-Salpêtrière Hospital in Paris, France. First, this is my disclosure slide. So what is the rationale for using high-flow VV ECMO in severe ARDS patients? Maybe the first population of patients who might benefit from this technique and strategy is those patients who are almost dying of refractory hypoxemia or for whom mechanical ventilation became very dangerous. These are data from 10 years ago now in the Australian and New Zealand series of H1N1 severe ARDS patients. And as you remember, there were quite good outcome with these patients. And as you all know, of course, we now have the severe coronavirus COVID-19 disease. I will talk to you about that at the end of this presentation. Also, patients, very severe patients almost dying for refractory hypoxemia. This might be a first population of patients who might benefit from this type of strategy. And there is another one population who might benefit from VV ECMO for those patients maybe a little bit less severe, but for whom the intensity of mechanical ventilation is still high, with high driving pressure, high volumes. And in those patients, ECMO might make it possible to rest the lung and to allow a less traumatic ventilation, and to minimize lung stress and strain, to reduce villi, volutrauma, barotrauma, telectrauma, biotrauma. All these might be permitted by VV ECMO. And if we believe that ECMO works in these patients, we need to start ECMO very rapidly to decrease the intensity of mechanical ventilation. There is a lot of paper showing that the longer the mechanical ventilation before ECMO, the more severe is the prognosis here. The mortality increased by 7% by each additional day of mechanical ventilation before ECMO. And in that series we conducted some years ago, those patients who got ECMO more than 10 days after the initiation of mechanical ventilation had much more severe disease. And this is probably because ECMO makes it possible to decrease the driving pressure. As you can see here, high driving pressure before ECMO, more than 20 centimeters of water, was strikingly decreased after the initiation of ECMO. Just the same for the tidal volume, just the same for the plateau pressure, also just the same for the mechanical power, the whole energy, which is transferred to the lungs here in a cohort of 350 patients on VV ECMO, the lifeguard cohort. So now, what might be the indications of VV ECMO after the publication of the EOLIA trial 2 years ago now? As you remember, this study showed that there was a non-statistically significant but quite striking difference between ECMO and control patients in terms of mortality, 35 versus 46. Of course, when we combine the deaths in ECMO patients and deaths all crossover to ECMO in control patients, there was a statistically significant difference in favor of the ECMO group. And as you also remember, we analyzed using Bayesian stats this EOLIA trial, which showed that the probability of ECMO saving lives in severe ARDS patients was between 88 and 99%. This is why it was written in an editorial following that paper that now the question should not be, does ECMO work? Because that question seems to be answered. ECMO works for severe ARDS. Now we need maybe to define how, in which population of patient, at what cost, etc. So what population of patients? Getting back to EOLIA, the inclusion criteria for EOLIA were 3 per the PF ratio below 50 meters of mercury for more than 3 hours, with potential recourse to NO, recruitment maneuvers, or prone positioning, or a second criteria which was close, but now the PF was below 80 for more than 6 hours, or a third criteria of respiratory acidosis, a pH below 7.25 with a PCO2 of a 60 for more than 6 hours, providing that a mechanical ventilation had been optimized. Also need to have a clear look at what were the exclusion criteria. Here we focused on patients with MV duration less than 7 days, We focused on patients not massively obese. Those who had comorbidities like chronic respiratory insufficiency were excluded, cardiac failure, malignancy, patients who had very high SAPS2 and a low probability of survival were also excluded. So this should be discussed carefully before the indication of ECMO in this population of patients. So now a few words about the latest VV ECMO in the context of severe COVID-19 associated ARDS. These are data we very recently published 10 days ago in the Lancet Respiratory Medicine. It's a cohort of 83 patients who were treated here in Paris in our university hospital network. And in those patients, we had even more stringent criteria for entry. Age was limited to 65 to 70. We excluded massive obesity patients. We also excluded patients with severe comorbidities, pretty much like in the EOLIA trial. We also excluded patients with severe immunocompromised status, those with hematological cancer, especially bone marrow transplant, which was shown to have a very dismal prognosis after ECMO. Also patients who had undergone cardiac arrest. And the duration, we may be a little bit less stringent. We limited that at 10 days. And also we excluded patients with multiple organ failure, maybe except those who had isolated acute kidney injury, which was quite frequent in these COVID-19 patients. And this is what we observed in these patients. The PF was at 60. It was lower than in the EOLIA trial. The compliance also was pretty low, and it was quite different from what was described for less severe COVID-19 patients. Here we're talking about patients with very low compliance, high driving pressure was just the same as in the EOLIA trials at 18. Mechanical power was very high, and the SOFA score also was very high. These patients had severe multiple organ dysfunction. And one main feature of that study is that virtually every patient were prone before going to ECMO. And on the right side of the panel here, you have the outcome of these patients. The day 60 probability of death was only 31%. It was pretty much the same, and that was observed in the EOLIA trial at day 60, and it was almost the same between 35 and 37 at day 90. So we got very similar results actually in these COVID-19 patients that we observed for the EOLIA trial. Here, this is the management of the patients. Tidal volume was strikingly reduced following ECMO initiation, around 2.5 ml per kilo. The driving pressure also was reduced around 12 and was very similar here in red for the COVID-19, in blue for the EOLIA trial patients. And looking here at compliance was also very similar between the two studies. And what we can observe here is that there was a more pronounced impact of the disease on the compliance that it was in the EOLIA trial. A few words about the outcome, other outcome of the patients. Hemorrhage, pretty much the same. More pulmonary embolism, which is a feature of COVID-19 also as compared to EOLIA. Stroke was very similar. More VAPs also in these patients who stayed longer on ECMO, almost twice as long. As you can see here, 11 days for EOLIA, 20 days for COVID-19. And the ICU stay also was much longer. So this is the strategy we might define now for VV ECMO. We clearly have to stick with the EOLIA entry criteria here. This is one of the algorithm we published a couple months ago. And we also made it clear that prone positioning should be part of the strategy before decision, except for those patients who have the most severe disease, those who have life-threatening hypoxemia. And when the patient qualifies for one of the entry criteria of the EOLIA trial, ECMO might be initiated in the situation where the patient has no contraindication, which also should be looked at. And so now this is my last slide. and also some words we wrote very recently in ISICEM or in Israel in intensive care medicine, saying no until the moment is right. ECMO should be part of the armamentarium treatment now for severe ARDS. It has been demonstrated that ECMO does not kill people, which was an issue a couple of years ago. ECMO will benefit to the most severe form of ARDS patients if the entry criteria of EOLIA are respected. It is possible to say yes to ECMO or not yet. For those patients who did not receive prone positioning, this should be the first step for sure. It's also possible to say no to ECMO when there is a low probability of surviving regarding age, comorbidities, organ failure, or degradation of, and there may be a combination of these different criteria. And one also of the main point here, we need to build networks for the decision, for treatment optimization, for retrieval of patients on ECMO for those centers who do not have on-site ECMO. And lastly, we need more studies now to maybe better define which population of patients will benefit the most, and to optimize also the strategy of treatment for those patients who are receiving ECMO. Thank you very much.